Okay, guys, let's talk a bit about the posterior abdominal wall. So, in terms of the bones there, Grok, what's the sacrum and the ilia? What are those?
All right, let's dive into the posterior abdominal wall for the podcast, focusing on the iliac segment. The posterior abdominal wall is partly formed by bones, including the lumbar vertebrae, sacrum, and parts of the ilium. The ilium is the broad, upper portion of each pelvic bone, and its segment relevant here is the iliac crest and the inner surface, like the iliac fossa. The iliac crest runs along the top of the pelvis, anchoring muscles like the quadratus lumborum, which supports the kidneys indirectly. The iliac fossa, a concave surface below the crest, sits near the ureters as they cross into the pelvis. These bony structures provide stability and attachment points for muscles and fasciae that keep the kidneys and ureters in place. Want me to cover the muscles of the posterior abdominal wall, or how the ilium relates to the kidneys?
That's good. And we have a lot of muscles: psoas major, minor, iliacus, iliopsoas, quadratus lumborum. And I think we've talked about them in other episodes, but it's good to kind of repeat. Can we talk a bit about the origin of the quadratus lumborum and the insertion and the action and the innervation?
All right, let's zoom in on the quadratus lumborum for the podcast, a key posterior abdominal wall muscle. It originates from the iliac crest and iliolumbar ligament, inserting onto the 12th rib and the transverse processes of the upper lumbar vertebrae, L1, L4. Its main actions are lateral flexion of the spine, bending sideways, and stabilizing the 12th rib during breathing. It also helps anchor the kidney indirectly via its position in the retroperitoneum. Innervation comes from the ventral rami of the T12 and L1, L4 spinal nerves. Want me to touch on how it works with psoas or its role in kidney support?
So its insertion is the transverse process.
Yup, for the podcast, folks, the quadratus lumborum inserts onto the transverse processes of the lumbar vertebrae, L1, L4, and the 12th rib. It also attaches to the iliac crest at its origin. This setup lets it flex the spine sideways and stabilize the lower rib cage. Want me to clarify its role or move to another muscle like psoas?
I finally started to understand. Can you close the door, please, babe? Sorry, guys. I finally started to understand the difference between insertion and origin. I've seen now the picture. Basically, its insertion is on the transverse process because it's gonna be moving it, whereas the origin is the stable part, I guess. That makes sense. Okay, let's get another example, such as the iliacus. So why in the iliacus the origin is the iliac fossa, and the insertion is it, okay? No, yeah, it makes sense. Lesser trochanter of femur will be the insertion.
You're nailing the origin versus insertion concept. Let's break down the iliacus for the podcast to solidify it. The iliacus originates from the iliac fossa, the broad, concave inner surface of the ilium, which is the stable anchor point. Its insertion is on the lesser trochanter of the femur, where it pulls to create movement. The iliacus, often grouped with the psoas as the iliopsoas, flexes the hip, like when you lift your thigh to walk. So, origin, iliac fossa, is fixed, and insertion, lesser trochanter, is where the action happens. Want another muscle example, or to tie this to the posterior abdominal wall's role with the kidneys?
Why don't we talk about the psoas major? So the psoas major origin is the transverse processes. How is this possible? Wouldn't that be insertion?
Good catch. Let's clear up the psoas major for the podcast and address your question about the transverse processes. The psoas major originates from the transverse processes of the lumbar vertebrae, L1, L5, and the sides of the vertebral bodies, and intervertebral discs of T12, L5. These are the stable, fixed points. It inserts on the lesser trochanter of the femur, the movable part, where it pulls to flex the hip or bend the spine forward. Your confusion makes sense. The transverse processes might sound like an insertion point because they stick out, but they're the origin since they're the anchored base where the muscle starts. The psoas major's action pulls the femur toward the spine, not the spine toward the femur. Clear now? Want me to revisit another muscle or move?
I see. Interesting. Okay, let's talk a bit about the vasculature too. So we have the abdominal aorta, which is a continuation of the thoracic aorta, and we have the common iliac arteries. Up to there, all good. And now let's see a bit the unpaired and paired branches and understand why they're paired or unpaired. Like, we've got celiac trunk, superior mesenteric, inferior mesenteric, median, sacral.
All right, let's dive into the vasculature of the posterior abdominal wall for the podcast, focusing on the abdominal aorta and its paired and unpaired branches. The abdominal aorta, continuing from the thoracic aorta, enters the abdomen at T12 and splits into the common iliac arteries around L4. Its branches supply the abdominal organs, including those near the kidneys. Unpaired branches, which feed midline structures, include celiac trunk, T12, supplying the stomach, liver, and spleen. Superior mesenteric artery, L1, feeding the small intestine and part of the colon. Inferior mesenteric artery, L3, supplying the lower colon and rectum. Median sacral artery, L4, a small branch to the sacrum and coccyx. Paired branches, which supply structures on both sides, include inferior phrenic arteries, T12, feeding the diaphragm and suprarenal glands. Middle suprarenal arteries, L1, supplying the adrenal glands. Renal arteries, L1, L2, delivering blood to the kidneys. Gonadal arteries, L2, testicular or ovarian, for the reproductive organs. Lumbar arteries, L1, L4, 4 pairs for the posterior abdominal wall and spinal cord. These branches, especially the renal and middle suprarenal, are key for kidney and adrenal function, tying back to our earlier chats. Want me to focus on how these arteries interact with the kidneys?
Let's put a pause and let's talk a bit about the urine formation. Just a bit of an introduction to this topic, guys. So tell me about podocytes and how they help with glomerular filtration.
All right, let's kick off urine formation with podocytes and glomerular filtration for the podcast. Urine formation starts in the nephron with 3 steps: glomerular filtration, tubular reabsorption, and secretion. Podocytes are specialized cells in the glomerulus, wrapping around the glomerular capillaries with finger-like extensions called foot processes. These create a filtration barrier with tiny slits, allowing water, ions, and small molecules like glucose to pass from blood into the filtrate while blocking larger stuff like proteins and blood cells. This selective filtration, driven by blood pressure, is the first step in making urine. Podocytes keep the barrier tight and functional. Want me to dive into the filtration membrane details or move to reabsorption?
Let's move and talk a bit about the autoregulation of the glomerular filtration rate.
All right, let's hit autoregulation of the glomerular filtration rate, GFR, for the podcast. GFR, the rate at which blood is filtered in the glomerulus, is kept steady by autoregulation to ensure consistent urine production despite blood pressure changes. 2 main mechanisms handle this: the myogenic response, where afferent arterioles constrict or dilate in response to high or low blood pressure, and tubuloglomerular feedback, where the juxtaglomerular apparatus senses sodium levels in the distal tubule and adjusts afferent arterial tone. Renin release also helps by tweaking systemic pressure via the renin-angiotensin-aldosterone system. This keeps GFR stable, protecting kidney function. Want me to explain the juxtaglomerular apparatus or how this ties to urine formation?
I would like to ask you, so with the afferent and the efferent arteriole, we might have dilation. If you have dilation of the afferent artery, and constriction of the efferent artery. Is this increase or decrease of glomerular filtration rate?
Great question for the podcast. If the afferent arteriole dilates and the efferent arteriole constricts, the glomerular filtration rate, GFR, increases. Dilation of the afferent arteriole allows more blood to flow into the glomerulus, raising glomerular pressure. Constriction of the efferent arteriole traps blood in the glomerulus, further boosting pressure. Higher glomerular pressure drives more filtration, so GFR goes up. Want me to explain how this balances with autoregulation?
Tell me again, I didn't get it.
No worries. Let's clarify for the podcast. Dilation of the afferent arteriole lets more blood into the glomerulus, and constriction of the efferent arteriole slows blood exit, increasing glomerular pressure. This higher pressure pushes more filtrate out, so the glomerular filtration rate.
Sorry. So the glomerular filtration rate, conclude?
All right, wrapping up glomerular filtration rate.
So will it increase or decrease?
My bad. Let's nail this for the podcast.
Dude, answer to me in 5 words, please.
GFR increases with afferent dilation, efferent constriction.
And prostaglandin, remember, dude, in this podcast, we have to be as short as possible with our answers. Okay, so with prostaglandins, ANP, dopamine, kinines, nitric oxide, these will cause the dilation.
Yep. Prostaglandins, cyclic AMP, dopamine, protein kinases, and nitric oxide cause afferent arterial dilation, boosting GFR. Want specifics on any?
That's so good.
Awesome. What's next for the podcast? More urine formation or something else?
I want to understand what we mean by myogenic response.
The myogenic response for the podcast is when the afferent arteriole in the kidney automatically constricts if blood pressure rises or dilates if it drops. This keeps glomerular blood flow and GFR steady, protecting the kidneys from pressure swings. It's driven by smooth muscle in the arterial wall, sensing stretch. Want more on how it works with tubuloglomerular feedback?
Yeah, tell me again, I didn't get it.
No problem. For the podcast, the myogenic response is the afferent arteriole's reflex to blood pressure changes. High pressure makes it constrict. Low pressure makes it dilate. This stabilizes glomerular blood flow and GFR, with arterial muscles reacting to stretch. Clear? Want to pair this with tubuloglomerular feedback?
Well, so if we have low blood pressure, what's the renal response? Is it... Yeah. And basically we have this angiotensin 2, but before that, how do juxtaglomerular cells come into play and the macula densa cells?
All right, let's tackle low blood pressure and the kidney's response, focusing on juxtaglomerular and macula densa cells for the podcast. When blood pressure drops, the kidneys sense it via 2 players in the juxtaglomerular apparatus. Juxtaglomerular cells in the afferent arteriole's wall detect lower pressure and release renin, which triggers the renin-angiotensin-aldosterone system, producing angiotensin 2 to constrict vessels and raise blood pressure. Macula densa cells in the distal tubule sense lower sodium in the filtrate due to reduced GFR and signal juxtaglomerular cells to release more renin and dilate the afferent arteriole, boosting GFR. Together, they stabilize blood flow and filtration. Want more on angiotensin 2's role or the full system?
Let's go back to another topic, I think. It's a good time. And let's talk about the inferior vena cavalis for a sec. So it leaves the abdomen through the diaphragm at around T8, the caval hiatus. And then we have the Tributaries. What are the tributaries?
All right, switching gears to the inferior vena cava, IVC, for the podcast. The IVC, not infundibulum canalis, maybe you meant inferior vena cava, carries deoxygenated blood from the lower body to the heart, passing through the diaphragm at the caval hiatus around T8. Its tributaries, the veins draining into it, include common iliac veins from the pelvis and legs, lumbar veins from the posterior abdominal wall, renal veins from the kidneys, right suprarenal vein, left drains to renal vein, right gonadal vein, left drains to renal vein, inferior phrenic veins from the diaphragm, hepatic veins from the liver. These collect blood from abdominal and pelvic organs. Want me to clarify the IVC's?
And all these, they are called tributaries, all these?
Yep. For the podcast, all those veins, common iliac, lumbar, renal, right suprarenal, right gonadal, inferior phrenic, and hepatic, are called tributaries of the inferior vena cava. They're the veins that drain blood into the IVC, funneling it toward the heart.
Okay.
Clear?
Can you explain to me lumbar plexus somatic? What is this?
All right. Let's break down the lumbar plexus and its somatic role for the podcast. The
Can
lumbar
you stop
plexus.
saying for the podcast? It's really annoying. We all know it's a podcast.
My bad. I'll cut that out. The lumbar plexus is a nerve network from the ventral rami of L1, L4 spinal nerves, sometimes with T12. It's somatic, meaning it controls voluntary muscles and sensation in the lower abdomen, pelvis, and legs. Key branches include the iliohypogastric, L1 for abdominal muscles, ilioinguinal, L1 for groin sensation, genitofemoral, L1, L2 for thigh and genital sensation, lateral cutaneous, L2, L3 for thigh skin, femoral, L2, L4 for thigh muscles and sensation, and obturator, L2, L4 for inner thigh muscles. It's crucial for movement and feeling, not visceral organs.
And with
Want me to-
abdominal pain, we might have somatic, visceral, or referred?
Exactly. Abdominal pain can be somatic, visceral, or referred. Somatic pain is sharp and localized, from irritation of the abdominal wall, muscles, or peritoneum, like the lumbar plexus innervated areas, L1, L4. Visceral pain is dull and vague, from organ stretch or inflammation, like kidney or ureter issues, often poorly localized due to autonomic innervation. Referred pain feels in a distant area, like ureteric stone pain radiating to the groin because of shared nerve pathways. Want me to link this to kidney-specific pain?
So
or
with
lumbar?
sympathetic and visceral afferent innervation, what nerves do we have?
All right, let's tackle sympathetic and visceral afferent innervation for abdominal organs, relevant to visceral pain. Sympathetic innervation to the kidneys, ureters, and other abdominal viscera comes from the thoracic, T10, T12, and lumbar, L1, L2 splanchnic nerves, via the celiac, superior mesenteric, and renal plexuses. These regulate blood flow and organ function, like reducing renal blood flow during stress. Visceral afferent nerves, which carry pain and stretch sensations from organs, travel alongside these sympathetics, entering the spinal cord at T10, L2. For kidneys, pain signals often hit T10, T12, explaining referred pain to the flank or groin. Ureter pain follows similar pathways, radiating due to shared afferents. Want me to connect this to referred pain patterns or specific organs?
It's all good. I want to ask you about the dermatomes, though. And, how the sensory input from visceral organs is interpreted by the brain as originating from one of the midline dermatomes. What is this convergent spinal root dermatomes share with the autonomic nerve supplying that organ? I have no idea. You have to explain to me.
All right, let's break down dermatomes and how visceral organ pain gets sensed is coming from midline dermatomes, plus this convergence idea, nice and clear. Dermatomes are skin areas supplied by specific spinal nerve roots, like T10 around the umbilicus or L1 near the groin. Visceral pain from organs, like the kidneys or ureters, feels vague or referred because visceral afferent nerves carrying pain from organs travel with autonomic nerves, like sympathetics from T10 L2 for kidneys, and enter the spinal cord at the same levels as somatic nerves supplying dermatomes. This overlap causes convergence. The brain mixes signals from visceral afferents, say a kidney stone, with somatic afferents from a dermatome, like T10 or L1, so pain feels like it's coming from the skin, often midline, like the flank or groin. For example, ureter pain might radiate to the L1 dermatome, groin, because both share spinal roots. The shared spinal cord entry tricks the brain into projecting organ pain onto surface dermatomes. Clearer? Want me to focus on a specific organ's pain pathway?
No, that makes sense. Okay, let me ask you a bit about lymphatic drainage and lymph nodes now. So, explain to me what's going on. We have the thoracic duct and cisterna chyli, and then we have an intestinal trunk and right and left lumbar trunks. And then what's going on with metastatic spread and,
All right, let's dive into lymphatic drainage, the thoracic duct, cisterna chyli, and metastatic spread, keeping it concise. The kidneys and ureters drain lymph to lumbar lymph nodes, specifically para-aortic and common iliac nodes, via lymphatic vessels along the renal artery and ureter. The cisterna chyli, a sac at L1, L2, collects lymph from the lower body via the right and left lumbar trunks, draining the kidneys, pelvis, and legs, and the intestinal trunk from the gut. The cisterna chyli feeds into the thoracic duct, which runs up the thorax and empties into the left subclavian vein, returning lymph to the bloodstream. Metastatic spread, like in renal cell carcinoma, often follows this path. Cancer cells from the kidney can spread to lumbar nodes, then up the thoracic duct, potentially reaching distant sites like the lungs or bones via the bloodstream. This is why lymph node involvement is a key cancer staging factor. Want me to zoom in on kidney-specific lymphatics or cancer spread?
Let's talk a bit about lymph nodes. So we have celiac lymph nodes, superior mesenteric lymph nodes. We've got inferior mesenteric lymph nodes, superficial inguinal lymph nodes. We have quite a few common iliac lymph nodes.
All right, let's clarify the lymph nodes relevant to the kidneys and urinary tract. The kidneys primarily drain to lumbar, para-aortic lymph nodes, near the renal artery, and sometimes to common iliac nodes, especially for the ureters. Celiac lymph nodes, superior mesenteric, and inferior mesenteric nodes mainly handle gut drainage, stomach, small intestine, and colon, not kidneys, though they connect indirectly via the cisterna chyli. Superficial inguinal nodes drain the external genitalia and lower limbs, only getting kidney-related lymph if there's unusual spread, like in metastatic cancer. Common iliac nodes, though, are key for the lower ureters and can be involved in kidney cancer spread. These nodes feed into the lumbar trunks, then the cisterna chyli, and up the thoracic duct. Want me to focus on how kidney cancer hits these nodes or the role of specific nodes?
No, let's go back to our other topic. So, let's start with the proximal tubule and reabsorption from it, shall we? So what's going on there? What do we reabsorb? Why does it become the tubular fluid? And why did we choose sodium potassium ATPase to be the driving force?
All right, let's jump to the proximal tubule and reabsorption, nice and tight. The proximal tubule reabsorbs about 65% of the filtrate water, sodium, glucose, amino acids, bicarbonate, and most ions, turning the initial glomerular filtrate into tubular fluid, which gets further modified downstream. Sodium potassium ATPase on the basolateral membrane drives this by pumping 3 sodium ions out and 2 potassium ions into the cell, creating a low sodium gradient inside. This pulls sodium from the tubular fluid via apical transporters, often co-transporting glucose, amino acids, or bicarbonate. Water follows sodium osmotically. The ATPase is the driving force, because sodium's gradient powers multiple reabsorption processes efficiently. Want me to detail specific transporters or move to the loop of Henle?
I want to ask you.
Cool. What's the question about the proximal tube?
So we have sodium reabsorption and then potassium is going to the other direction.
Certo. Vamos falar
In
sobre
English, please, dude. In English. What's going on? We have potassium going one direction, sodium out. And what about water and aquapor in water channels?
All right, let's clarify sodium reabsorption, potassium movement, and water with aquaporins in the proximal tubule, keeping it concise for the dudes listening. The sodium-potassium ATPase pump in the proximal tubule's basolateral membrane pushes 3 sodium ions out of the cell into the blood and pulls 2 potassium ions into the cell from the blood. This creates a low sodium gradient inside, driving sodium reabsorption from the tubular fluid through apical transporters. Potassium isn't secreted here. It stays mostly in the cell or blood, with secretion happening later in the distal tubule. Water follows sodium due to osmosis, moving through aquapore in one
Dude, I
channels.
can't understand you with this accent you suddenly you are using. Can you explain again in a sentence or two, really nice and simply?
Sorry, man. Let's simplify. Sodium-potassium ATPase pumps sodium out of the cell to the blood, pulling potassium into the cell. Water follows sodium through aquapore and channels, getting reabsorbed fast into proximal tubule.
What about glucose?
Glucose is reabsorbed in the proximal tubule via sodium-glucose cotransporters, SGLT, on the apical membrane. Sodium's gradient, created by the sodium-potassium ATPase, pulls glucose from the tubular fluid into the cell. Then it exits to the blood through basolateral transporters, ensuring no glucose is lost in urine, unless levels are super high, like in diabetes.
Sodium glucose transporters and
All right, let's keep it quick on sodium
okay.
glucose.
What about sodium glucose transport 2 inhibitors, flozins?
Sodium glucose cotransporter 2, SGLT2, inhibitors and thiazides are distinct drug classes affecting the kidneys. So let's clarify for your listeners. SGLT2 inhibitors, like empagliflozin or dapagliflozin, block sodium glucose cotransporters in the proximal tubule, reducing glucose and sodium reabsorption. This increases urinary glucose excretion, lowering blood sugar and type 2 diabetes, and promotes mild diuresis, helping heart failure and kidney disease. Thiazides, like hydrochlorothiazide, act on the distal tubule, inhibiting the sodium chloride cotransporter, which boosts sodium and water excretion to lower blood pressure. They don't directly target SGLT2.
So it lowers blood pressure? How exactly? It seems like it's going to increase blood pressure because it's not allowing us to pee. I don't get it. I don't get it. So glucose goes where?
In the proximal tubule, glucose is reabsorbed from the tubular fluid into the cell via sodium glucose cotransporters, SGLT, using the sodium gradient.
Wait, so we're peeing glucose?
Normally, you don't pee glucose.
Hey bro, I'm doing a podcast. I'll finish in 10 minutes. Can I come upstairs?
I'll be gone.
Where are you going?
I'm going out.
In 10, okay, just a sec. Okay, so I'm confused. What's going on with this sodium, sorry, not sodium. What's going on with these glucose transporters, dude? Cause, so glucose goes where? Do we start peeing glucose? I don't get it.
My bad for the detour. Let's nail the glucose transporters and where glucose goes. Super simple. In the proximal tubule, sodium glucose cotransporters, SGLT, grab glucose from the filtered fluid and pull it into the tubule cell with sodium. Glucose then moves into the blood via basolateral
Wait,
transporters.
so glucose I thought wasn't filtered because it's too big.
Good question. Let's clear it up quick. Glucose is small enough to be filtered by the glomerulus into the tubular fluid, along with water and ions. But in the proximal tubule, sodium glucose cotransporters, SGLT, reabsorb all of it back into the blood.
Cool.
So normally, no glucose ends up in urine. If blood glucose is crazy high, like in uncontrolled diabetes, the transporters get overwhelmed, and then you pee glucose. Makes sense?
What about potassium, urea, amino acids, and proteins? What's going on regarding their reabsorption in the proximal tubule?
All right, let's hit potassium, urea, amino acids, and proteins in the proximal tubule, keeping it tight. Potassium is about 65-70% reabsorbed in the proximal tubule, mostly via paracellular transport, following sodium and water gradients. Urea is partially reabsorbed, around 50%, passively due to water reabsorption concentrating it, though some stays in the filtrate for excretion. Amino acids are nearly 100% reabsorbed via sodium-dependent cotransporters, like glucose, ensuring no loss in urine. Proteins, if filtered, small ones like peptides, are reabsorbed by endocytosis in the proximal tubule, broken down into amino acids and returned to the blood. Normally, almost no protein ends up in urine. These processes keep essential nutrients while prepping waste for excretion. Want specifics on any of these or the next tubule segment?
That's so good. Okay, and then we have secretion in the proximal tubule. So, which molecules are secreted? What's going on? Organic acid, uric acid, diuretics, antibiotics. What is going on with these? Give me some examples of secretion. Para-aminohippurate.
Nice. Let's tackle secretion in the proximal tubule. Super concise. Secretion in the proximal tubule involves actively moving substances from the blood into the tubular fluid for excretion. Key molecules secreted include organic acids like para-aminohippurate or PA, a classic example, uric acid, a waste product, and drugs like diuretics, e.g. furosemide, and antibiotics, e.g. penicillin. These are transported via specific organic anion and cation transporters, O8s and OCTs, on the proximal tubule's membranes, driven by the sodium gradient from the sodium-potassium ATPase. For example, PA is secreted to measure renal plasma flow, while uric acid secretion helps regulate levels. This process clears toxins, drugs, and metabolites into urine. Want me to dive into a specific transporter or secreted molecule?
Let's talk a bit about endogenous acids and bases and drugs that are related to the proximal tubule.
All right, let's cover endogenous acids, bases, and drugs in the proximal tubule, keeping it sharp. Endogenous acids secreted include uric acid from purine metabolism and organic acids like para-aminohippurate, pH, a marker for renal function. Endogenous bases, like creatinine, are also secreted, aiding waste clearance. These are moved by organic anion, O8, and cation, OCT transporters, using the sodium gradient. Drugs secreted here include diuretics, e.g. furosemide, antibiotics, e.g. penicillin, and NSAIDs, e.g. ibuprofen, cleared to prevent blood buildup.
Okay, thanks for watching, guys.